Okay, I'll start with a real case scenario which we managed last year in our hospital. So it's basically about two diseases I'll be talking about very, very briefly. And the first one is PSC. So a young female, 37 years of age, who had ulcerative colitis for last 7 years, which was quite well controlled, presented to our hospital in PEMH, Rawalpindi, last May. And she presented with fever, yellow discoloration of eyes. Her ulcerative colitis was quite well controlled. She was spiking temperature 101, 102, associated with rigors and chills. She had progressively worsening jaundice and generalized body itching. If we go back a little bit, a month before she came to us, she was admitted in one of the hospitals in Jeddah, Kingdom of Saudi Arabia, where once she was scanned, she was found to have two dominant strictures. So she had ulcerative colitis, she had PSC, and they found that she had two dominant strictures, one in the left left biliary system and one in the common hepatic duct. They tried to negotiate it through ERCP, but the strictures were too tight to negotiate through. Considering that she had recurrent episodes of cholangitis, she was asked to undergo liver transplantation and she was being assessed for that. Her brother was, the whole family was from Pakistan, so they thought of getting a second opinion from Pakistan and they came to us. Just briefly, regarding her past history, ulcerative colitis was well controlled. She was on mesalamine and azathioprine, which was started after she had 3 flares in the past. Nothing significant in personal or family history. Same goes for the travel and socioeconomic. These are the drugs she was on. So once we examined her, she was tachycardic, was spiking temperature, she was jaundiced. On examination, she had two drains in place. One was the PTBD, which was in the left hepatic system, and the other one was free peritoneal drain on the right side. Nothing to mention about in central nervous, cardiovascular, or respiratory system. So she got admitted with us. We sent blood samples for labs. It turned out she is anemic. Her full liver disease screen was negative. So this is her liver profile. Her bilirubin was quite high and same was her alkaline phosphatase. Her ultrasound abdomen did not show much except for mild dilatation of the biliary tree, intrahepatic biliary tree. The extrahepatic biliary tree was all fine, looked all fine on ultrasound. Her fibroscan reading was slightly higher, which we believe was because of bile stasis. No varices on endoscopy. So if I could just explain what the people in Jeddah found on MRCP. So she had one dominant stricture over here, which is the left biliary tree, just prior to the confluence. And this could not be negotiated through PTBD because after they could not do ERCP, they went for PTBD, but they could just place the drain up to here. And this stricture could not even be negotiated through PTBD. And then one stricture, dominant stricture, was down there in the common hepatic duct. And this was earlier attempted with ERCP over there and could not be negotiated through. So now she had two strictures and a drain which was up to this point in the left biliary system and one drain in the peritoneal cavity on the right side. We wondered if we should go for another ERCP. My opinion was that in such cases, we need to treat her cholangitis first, so she should better go for PTBD, and that should be done. These strictures should be negotiated through PTBD, because certainly this would not have been an easy or straightforward ERCP. So we asked our IR team, they did this cholangiogram, This is the right biliary system. This is the left biliary system, the confluence, external drain on the right side, which was in the peritoneal cavity. And then this is the PTBD drain. So now this was all done over here. They tried to put this drain into the left system and they tried to negotiate through this first dominant stricture, which was in the left biliary system. So if you see that this left biliary system is this all looks like to be beaded with lot many strictures. And this gave us a picture that this dominant stricture has probably caused secondary sclerosing cholangitis over here, and this is all damaged because of that. So our IR team took the guide wire from the left system through the stricture, which was in the left biliary system, and they balloon dilated it. However, they found it again very challenging to go down through the common hepatic duct stricture. So they just took the drain from the left into the right system, at least to treat her ongoing cholangitis. And then she came, and then we thought that might as well go for ERCP. Let's see if we can negotiate the stricture of common hepatic duct. The contrast was not going up, it was all trapped below the stricture. Luckily, we got the wire through the stricture into the right system. And then we did dilatation with Sohindra dilator. And ultimately, we could place in an 8.5 French stent through the stricture. And this went right up to the confluence. And now we wanted to assess if this stent is really going to function and if we could take this external drain out. Because this stricture had been balloon dilated, we were not concerned about that. We were only concerned about the stricture in the common hepatic duct where this stent was placed. We placed 8.5 French stents, so we wondered if it's going to function or not. We asked our IR team if they could do a cholangiogram. So this is the cholangiogram at baseline. The contrast entering from here went all into the right system. They clamped this after pushing the contrast in. After 5 minutes, the contrast from the right system started draining down through the stent. After another 12 minutes, that is total of 17 minutes, nearly all the contrast had washed out through the drain. So then that made us believe that the stent which was placed through ERCP is functional. Now, if we look at the readings here, at baseline, last year, May, when she presented in Jeddah, her bilirubin was 257. It came down to 206 when PTBD drain was placed proximal to the stricture in the left biliary system. And then when PTBD was done here, when they negotiated through the stricture of left biliary system, it came further down to 150. After ERCP, it came down to 73 when the second stricture was also negotiated through. After removal of PTBD drain and few days after the stent was placed, and later on we upsized that with the 10 French stent, and this was her final reading. And about 6 weeks ago, we asked, the lady has gone back to Jeddah, and we asked if she could send the latest labs, and her bilirubin had come down to 16 then. Sorry. So this 257 came down to 16 over 6 to 7 months time. And similarly, the alkaline phosphatase came down as well. So it's been more than 8 months now, and she has not had requirement for any assessment regarding liver transplantation. So it was about basically a dominant stricture which was treated through both balloon dilatation and placement of the stent. So if we could just talk briefly about which one is superior regarding stent placement or the balloon dilatation for the dominant stricture. So this is one of the systemic reviews which was done last year and meta-analysis. According to this meta-analysis and systemic review, balloon dilatation and stent placement for dominant stricture, they both show similar results. However, the stent placement is more of a risk for potential complications, in particular cholangitis. So let's see how this lady progresses now, because she has been balloon dilated and has stent in situ as well. So this is just about PSC in my talk. And now very briefly about primary biliary cholangitis. We suspect primary biliary cholangitis when we find that the alkaline phosphatase levels are high, whether the lady has got typical signs or symptoms of PBC or not. In that case, we do scans like either ultrasound or, if required, MRCP to exclude any extrahepatic biliary obstruction. And then we check the anti-mitochondrial antibodies. There are certain situations we come across. So what to do when alkaline phosphatase is high, anti-mitochondrial antibodies are positive with a titer of at least 1:40, and the clinical picture is suggestive of PBC. Suggestive means middle-aged lady with no other ongoing liver disease. In that case, we won't go for liver biopsy and we will assume and treat it as PBC. So what to do when we find raised alkaline phosphatase and raised and positive AMA, but the picture is not suggestive? Could be male, could be of like maybe having conditions suggestive of NASH, like diabetic, obese. In that case, we can go for liver biopsy to confirm and stage the disease. Regarding raised ALK phos and negative AMA, again here we will consider doing the liver biopsy. Normal ALK phos, positive AMA with high suspicion like middle-aged lady, we may not go for liver biopsy. And if in doubt, then we consider liver biopsy. If both are not indicative of PBC, normal ALK phos, negative AMA, we have like sort of excluded PBC in this situation, and we need to consider other causes of deranged liver profile. PBC has changed a bit in last 3 decades. So this is a study which was conducted. It was an observational retrospective study which was conducted over a period of many decades. So they took 3 cohorts in this study. One was they recruited patients of PBC who were diagnosed with PBC from 1982 till 1999. Second cohort was from 2000 to 2010, and the last cohort was from 2011 to 2016. There were around 508 patients, and it was found that compared to the patients who were diagnosed in the first cohort, like before 1999, the male to female ratio was quite different. So it was 1:16. And when they compared it with the last cohort, which is from 2011 to 2016, the male to female ratio was 1:4. So from 1:16, where with female predominance, it went to 1:4. So this is how there has been an increase in male to female ratio. Similarly, regarding the age of diagnosis, there has been an incremental rise in the age of women who were diagnosed with PBC. So initially, the average age was 54 years, and subsequently they found that the average age now is 60 years. There has been good response to ursodeoxycholic acid. They said they concluded that nearly 30% of the patients responded to ursodeoxycholic acid in the first cohort, and nearly 70% have responded as per the Barcelona criteria in the last cohort, which is from 2011 to 2016. And similarly, they found better survival. So overall, they concluded that this better response and longer survival is most likely because of the early diagnosis of this disease. Now, the question is what to do when our patients do not respond to the standard doses of ursodeoxycholic acid. There has been a debate whether to increase the dose or not. So there was a study which was published this year in one of the journals of Germany, where they said that this is that study. So they took two cohorts, 73 patients who did not respond as per the Paris 2 and Barcelona clinic criteria. 73 patients did not achieve remission, or we can say did not respond to the standard dose of ursodeoxycholic acid. They divided those 73 patients into two cohorts. First was continued to be on a standard dose, and the second one was given high dose, which was 18 to 22 milligram per kg body weight. Over a period of 12 months, they found a significant difference in the two groups. The first cohort, which was continued to be given the standard dose, in that case, the response rate was 47%. And in the second group, where the dose was increased, the response was nearly 60%. So it was suggested that before going on to the second line drugs, there is an option that we could increase the dose to 18 to 20 milligram per kg body weight of ursodeoxycholic acid. Now the last point here, what are the extrapyramidal signs or symptoms in patients who have cholestatic liver diseases? Manganese and copper are mainly excreted through liver and the biliary tree. But what happens during cholestasis is that they get accumulated and get deposited in the basal ganglia, leading to extrapyramidal signs in the patient. Now, if we have a look at this study, which was published in the Scandinavian Journal, and this was from 2021, the aim was to see the effect of cholestasis on manganese and copper levels in the blood of patients with PBC and PSC. So there were three cohorts, those 20 patients of PBC, patients of PSC, and the control group. Patients who had PBC or PSC, they did not have significant difference in their blood levels of manganese and copper, but patients who combined these two groups, they certainly had significant difference in manganese and copper levels compared to the controls. So in this group, in these two group of patients, the manganese and copper levels were certainly high. So what they found was that if patients are treated with ursodeoxycholic acid or they undergo liver transplantation and we remove this problem of cholestasis, then lab cholestasis markers get normalized, the levels they come down, and patients are protected against these extrapyramidal signs. Therefore, we need to not only monitor cholestasis, we need to look for liver functions, manganese and copper levels, and also to look for extrapyramidal symptoms in patients who have cholestatic liver disease. So I'll end here and happy to take any questions. Thank you.